Well, since those of you who are listening right now don't have the benefit of being at our session in person, there were a lot of discussion points that were brought up by our students that I think are important to reiterate here for those of you that are watching after the fact. So one of the students brought up, in regards to conferences, tweet chats, or even more broadly, how do you balance the focus in medical school on evidence-based medicine with the popularity and reach of social media? And specifically, they're talking about the conference example I gave earlier. If someone is retweeting a factoid or what is appearing to be a fact, and then it gets picked up by another person, and now that has a wide reach of 50,000 or 100,000 people, but it's not necessarily a true fact. How do you balance those two pieces? How do you balance the traditional evidence-based approach to vetting content that's in social media or online? And I think that just represents sort of a bigger issue and a bigger problem, that we don't really have a good recipe book for all of this. We really don't have a great approach yet for balancing these two needs. There's not a good way or an established way yet that we can curate content in social media or on the web. And it really is important, even though anyone can be involved, from patients to physicians, it's really important that as physicians we do get involved so we can help our patients better navigate all the content that's out there. Because, if you can imagine, if we as physicians or students are having problems determining what's legitimate content, how do you think our patients feel? So I think it's a responsibility for us to try and figure out what is good and what's bad content. I mean, the best thing, for example, would be, say, the flu shots and vaccines and autism link. I mean, that's been a debate that's been going on for years and years and years. And most recently, in reviewing the initial research, they found that there was no connection at all. And all of this debate back and forth, there is no connection between the two. But still, there's a huge undercurrent of people who believe that the two of them are closely linked, and though there is no medical fact to back it up, how do you balance those two pieces of the puzzle? And I think that provides a good example for that. If Ashton Kutcher or Ellen DeGeneres started tweeting incorrect medical data, how do you balance those two things out? So I think it's important that we develop, as physicians, a mechanism to look at what's going on in social media, and just being able to vet content and curate content for our patients to help them better navigate this as well. Another great point from one of our students, this is Martin, one of our current third years, and he was saying, all of this is going to happen no matter what we do, and he's referring to social media. We're either going to try to get engaged, experiment, make mistakes, and finally figure out how to engage as doctors in a public online sphere, or the other option is that we don't do it, and everyone else will have the discussion and we won't have a voice. And he was saying that this is probably more dangerous, not having a voice, than the number of mistakes we make in trying to figure out how to do this. And I think for me, this is, this kind of hits home that, one of my students came up with this on their own, that they started to realize the importance of just being involved or being a participant in the discussion, whether or not you need to have an active voice. Just being there along with the discussion gives you a voice. And I think this goes back to the whole concept of, are we talking about sins of omission or sins of commission, or in this point, mistakes of omission or mistakes of commission? Is it better to not be involved and play it safe, and then you don't have a voice, or is it better to get involved, make a couple missteps along the way, but still be an active participant? And I think that's a point that it's up to you to decide how to manage that balance, but something to really think about. So another discussion that we had here, some people view getting involved in social media as a liability, but in the near future, they see it as more of a liability to not get involved. Again, these are kind of thoughts from our students. If you don't actively engage and control the message, you lose it. And society is changing. The concept of personal privacy is fundamentally changing. And when you talk about personal privacy, this applies to personal health issues. I mean, before, people would not talk about health issues at all, even with close friends. And now you see friends on Facebook asking, does anyone have recommendations for a good GI doctor or a good cancer doctor because their family member has been diagnosed with breast cancer. So there's a big change in people's comfort with sharing personal information that's very pervasive in the population, but hasn't really been picked up yet in the medical field. And so, all these different things are going to play into what potentially is going to be your role in social media. And so, I tend to agree with the thoughts that if you don't actively engage and control the message, you lose it. It's very easy for patients to, look at what people view as maybe experience being confused for expertise. And I think that's just sort of a great comment, that just because a lot of people talk about it doesn't mean it's necessarily legitimate. And that's our job as physicians to determine or help guide what can be legitimate data and legitimate fact in social media. Another great point here, in regards to the message, which is better, hundreds of individual feeds versus a single unified voice. And then another question, will there be a critical mass of social media physicians where your voice will get drowned out? And I think these are pretty insightful questions. Should all of the med students create a Twitter feed or a social media presence? And if they do so, does that make their individual feed less important? And that whole critical mass concept. And I think it really depends on the impact that you want, or what is your goal in putting content out there. If you're putting content out there just for the sake of putting content online, then possibly your message could be lost and maybe you won't have very much impact. But if you agree with, one of the options is if you're part of a professional society and you're very in line in the views that they have, I think it's adequate, and I think it's perfectly reasonable to forego being actively involved yourself in the discussion as long as you support the views that your society puts forward on Twitter or Facebook or their blog or their statements as well. It would be important for you, I think, to know what presence they have and point people or your patients in the right direction to resources that are representative of your views without having to actually come up with your own views yourself and create your own content. I think that's reasonable, but to some degree that involves a degree of involvement. That was a very repetitive statement, I'm sorry about that, but to even just curate data means that you're being involved, and I think that's at the bare minimum what is necessary. And some people, though, even though they agree with their societies, they feel they need to do more. And one of the examples I want to give is, for me being an emergency physician, we saw a lot of patients, pediatric patients that were referred in by the primary care doctor that had a lot of concerns about pediatric emergencies, and they didn't feel that they were getting a lot of support and guidance from either their local community or local physicians, and came to us while they were in the ER to ask a lot of these questions. And we found ourselves repeating a lot of the same data over and over and same recommendations over and over. We thought, wouldn't it be great if there was a format or a venue where we could share this information in a more impactful way than just a bunch of papers at the time of discharge? And so what my colleagues and I created was a site called Monkey Beans, and it no longer is up and running, but it had little video tutorials put together answering questions that we received very commonly from patients. And at the time we launched this was around the time of H1N1, so there was a lot of questions regarding that. And we'll see a video here on concussion and head injury. It was sort of springtime, and we'll take a little sample of it here.
Hey everyone, it's Dr. Wickman and Dr. Almer from Monkey Beans. Today we're going to talk about more of a timely, seasonal type topic. We're going to talk about some sports injuries. So, Omar, there's a case I had just recently. I just kind of want to run it by you and let me know what you think. 8-year-old kid playing soccer, out in the field, accidentally headbutts the other kid, goes down, actually passes out for a few moments, and then starts getting up, complains he's got a little bit of a headache. Parents are concerned about it after the game, bring him to the ER. What sort of things do you typically look for? What sort of things do you want to know? What would you do with this kid?
So this is a very interesting question, especially now.
So this Monkey Bean site was initially the brainchild of Omar Amer and Zareth Irwin, and they're both practicing emergency docs right now. And we felt that this was very helpful. We had a good number of members on the site. It was free membership, and we felt that it was very helpful, and they had a lot of great feedback for these comments, and it was a way for them to be able to interact to some degree with the physician, to ask questions to us that we commonly received, and we felt pretty comfortable in answering them in this format. And we felt that this was a little bit more engaging than simply a stack of papers at the time of discharge. I mean, if you remember from the last session we had where we talked about information design, how useful is an 8-page summary of recommendations versus a 30-second or 1-minute video describing what to look out for in signs of a concussion. And so we felt that this had impact. And in the larger picture, did this do a lot for the emergency medicine or pediatric emergency medicine community at large? Probably not, but for the 100+ members that we had that viewed the site, for them it had meaning. And I think that's the impact that you're looking at. For your audience, your patients, will this make a difference, or will this change behaviors, or will this be useful to them? So after we talked about this, one of the students said, I like that idea of your focused audience, but what happens if someone interprets that information incorrectly? Are you held liable? And this is sort of a tricky area because you are talking about medical data, medical advice, but you're not giving it specifically to a patient, but it's general medical advice. And if you go to any medical site, eMedicine or Medscape, there's a lot of disclaimers littered all over the place saying, always consult a physician. It's always the fine print that in theory should cover you in case of anything bad happening. The way that we approach this is, we are ER docs. These are questions we get frequently by our emergency room patients. If at any time you're listening to this and you feel uncomfortable or you're just not sure, you need to come see us in person in the emergency department. And I think that's a risk that we were willing to take, that people would take this information, because at the same point, we're putting out what we think is the best information regarding concussions and what we would do for our own children in this scenario. But there's probably thousands of other websites out there that have different recommendations for concussions that may not tell them to go to the ER at all. And so I think that for us putting our information out there, this is stuff that I tell my patients day in and day out, and I don't feel any more exposed or like I have more risk by putting this out on the web, because this is how I practice medicine and this is how I do my daily practice. Now, if you had me talking about things that were outside of my scope or comfort level, I may feel a little bit more different about that. Now, there's another site out here called HealthTap, and what they're doing is something a little bit differently, helping to mitigate that risk. And so if you look at this HealthTap site, what they actually do, it's sort of a collective of U.S. physicians, and what you can do is ask a question. So this question I put in there, when do I need a head CT? And so what it does is it looks through all the people that have asked this question beforehand, and you can find one that best fits the question that you have, and you'll have answers from physicians. And you can see in the upper right-hand corner there that says 5 doctors agree to Dr. Timothy Mosher, and then Dr. Pamela Pappas also answered with 1 doctor agree. And so you're getting this sort of collaborative physician pool that works together to give good advice. And so when you click on one of the physicians, I think this one is Dr. Pamela Pappas. She gets a doctor score, tells you a little bit about her, but it tells her what she's known for, what she gets votes for, how many doctors approve of her message, how many doctor agrees, how many thanks, how many followers. So this helps you sort of get a better picture for who's giving this content. And it's not just you trying to validate what one doctor is saying. This is a team of physicians. There's 16,000 in their whole group that say, all right, is their advice to an average patient legitimate, yes or no? And I think that helps kind of provide a little bit more security and a little bit less risk by it having these interactions online for general medical inquiries. Another good question here about how do you balance personal and professional personas. And one of the points specifically we had after talking about Wendy Sue Swanson was that she had a post on her Twitter feed around the time of the debate that said, watching the debate on behalf of U.S. children from hashtag AAP12, which is the American Academy of Pediatrics 2012 meeting, Obama, protect and help us provide exceptional care for all children. And so one of our students said, well, I thought you talked about before how maybe we shouldn't polarize or bring up political views. And he said, I don't really know much about Wendy Sue Swanson, but that implies that maybe she's a Democrat and she's for Obama. And would that necessarily alienate her audience? And it possibly could. Then again, depending on her geographic region, Seattle may be very pro-Obama. So for her, it's not a polarizing statement potentially. But you have to realize that whatever you put out there, again, it's a matter of perception and context, that for this individual or for any other individuals that may not be of the same political belief, they may look at what she's saying now and say, well, even though your message is to provide better care for children across the board, whatever policy comes into place, you are a Democrat and I'm not really a big fan of yours. So it can be as fickle as that, how decisions are made and how your impact can be lessened by these sort of items. But these are the sort of things you have to look at, which if we take Dr. Vardabadian's advice when you're starting out, stay as neutral as possible. As you're building a reputation, you want to sort of build this persona, and maybe being neutral is very useful up front. Then again, if your persona is driven primarily around political beliefs or special interests, then maybe you should stick with that as well. One of the other students also brought up too with this whole personal professional balance is, he spent years and years avoiding Facebook, or when he actually signed up for Facebook, keeping that very, very personal and private. How does that affect what he does on Twitter now? How does he get involved in social media knowing that on his Facebook page there are pictures from a couple years back that aren't the most flattering? Now, I'll be the first to say that on my Facebook account, I have the strictest settings for privacy. And if you haven't gone through your privacy settings on your Facebook, it's very important to do so because they change those pretty frequently. And it can be very surprising how many people can view your profile and your pictures. So make sure that you go through each section of the Facebook's privacy settings, looking at photos and posts, who can actually see them. The most secure, of course, would just be friends, not even friends of friends, just to help keep your private content private. That being said, it's not really private if you're running for political office or some other scandal. This could be used against you. But if you have photos from your med school retreat where you were doing a keg stand or drinking at a party, and you want to delete those, but they're still physically online, those are going to always be there, but you don't necessarily want those to be the first images people see of you. One of the other students had a recommendation is, he's got his own Facebook account, but he likes using Twitter now because he feels like he has more control over the message. And, unlike Facebook, where people can tag you in photos, post other things up on your photos, you don't really have complete control over your brand on Facebook. Twitter, he feels he has more control over. Same with LinkedIn, and that he can use that as more of a venue to put out information or share information he finds very useful. The one thing that I do think is really important, though, that we bring up is that, public scrutiny has always been a part of the medical profession. It's always been there from the very, very beginning of the profession. And it's just a lot easier now to have that because of social media, and that whole private personal line is a little bit more blurred than it ever was before. But you could always, screw up in public previously and make a spectacle of yourself. It's just a lot easier to do so right now. I've heard people say before that the barriers to doing stupid things right now are at an all-time low, and stupidity is just one click away. And we've even talked about before that, just like drinking and driving, things you don't want to do together, texting and drinking, social media and drinking, Facebook, drunk dials, all those things you don't want to do in a state where it lowers your threshold for doing stupid things. There's a study out there that says 11% of all sexting goes to the wrong person. And just imagine that scenario if you were to engage in that kind of if you're going to engage in those sort of antics that you accidentally, instead of sending a direct text to someone, you accidentally tweet out, a sext to your entire audience. And so these are things that you have to be very, very careful about, because again, that threshold, that barrier to doing stupid things is a lot lower now, and you need to be careful about it. Another good point here, how do you get started with social media in the traditionally more conservative specialties? One of the students said, emergency medicine and pediatrics seems pretty well equipped. What about surgery, for example? And, if you talk about specialties, one of the things you can do easiest is to locate within your specialty who are the leaders in social media in your specialty. And every specialty has them. Surgery has people like Mary Brandt, also from Baylor, Texas Children, and she's at a very high level in her department, vice chair, but she's extremely active on Twitter, has a great following, talks about things like wellness, as we talked about earlier, but she's a surgeon, and some people don't equate surgery with being on the cutting edge of social media, but she is a role model in that specialty. There's Dr. Vardabadian, who's a pediatrician. There's Wendy Sue Swanson, pediatrician. Mike Sevilla, who is family medicine. There's a lot of great names you can find within your specialty to sort of latch onto, to reach out to get advice and guidance in generating your whole digital footprint in your specialty. Now, when you look at what content you want to develop, thinking about that post earlier from Dr. Vardabadian about repurposing medical content or physician knowledge, thinking about what's more accepted nowadays. And you have to think, CME, continuing medical education, is an area where items like podcasting and online quizzes are becoming more and more prevalent. And people, even the more established and senior physicians, are getting more comfortable with the idea of distance learning, web-based learning, podcast learning. And so if you're looking at an easy area of entry, maybe this is an approach that you can take. Creating a blog with a case of the day done as a quick podcast, or images of EKGs or x-rays or tricks of the trade, those kind of areas. These are areas where I think it's very easy for existing physicians or established physicians to be okay and comfortable with that content. The newer learners, residents and medical students are also pretty savvy and comfortable with this format, and it's probably an easy place to get started. From there, once you develop more of a rapport, you can move into items like purely going to video podcasts through YouTube, or going to Twitter or other different platforms. But I think the blogs focusing on your content is probably an easy place to begin. But again, look at, try and locate within your specialty physicians that are doing this very, very well, and reach out to them. The other thing to look at too is that at the American Academy of Pediatrics 2012 conference, they spawned a new term to describe pediatricians using Twitter, and that's tweetiatrician. That's TWEETIATRICIAN. Kind of hard to say and spell, actually, but I'll put it up here for you to check out. But pretty much they talked about just the role of the pediatrician and Twitter, and they as a society have really latched on to social media, and so they're probably on the cutting edge. And if you're looking at examples, you can look at pediatrics, but then try and model their experience within your own specialty. Another question here, are you concerned about physicians rating services online, patient satisfaction scores? What about procedural complication rates? How do those affect those scores? And again, these are things that I want to bring up have always been around, or they've been around for quite a long time. Patient satisfaction has always been an important part to practices, and have always been ways, whether it's phone call surveys or written surveys after the visit, at which patients can evaluate their physicians. The only difference now is that this data is out there and public, and so potential consumers or patients can look at ratings and make evaluations on which doctor they want to go to. But to some degree, that's always been there, and that's always been something that's been out there. And when you think about it, though, evaluations or grades are kind of always against you as a physician from the start. So just think about Yelp for a second. And for any of you that have used Yelp or have done any sort of rating on Amazon or any other sort of e-commerce site, what was the last review that you've done? Or I should say, how many reviews have you done that have been positive in nature? How many times have you gone to a restaurant and said, wow, that was an amazing meal, I need to write about that? Probably not as much, right? Oftentimes what happens is you have a bad experience and you say, I need to tell people about this bad experience or about this terrible product so no one else makes the same mistake I do. There's more of an incentive to us internally to talk about letdowns than there are to talk about praise. And it's kind of funny when you talk about that concept. There's a great little excerpt out of this book called Brain Trust, called Disappointed or Pleasantly Surprised, Adjust Your Expectations. And this guy Gordon Dahl from University of California, San Diego, talks about this whole gain-loss reference dependence. And he says it's not really about the amount of liquid in the glass, whether it's half full or half empty. It's about how much you expect there to be in the glass. And so, an unexpected great meal at a decent restaurant equals a good amount of happiness, but it doesn't balance a great restaurant completely screwing up a meal. And so there's a sort of inequity of value for happiness. Like the first scenario would be sort of a happiness of +3, whereas the second scenario of a disappointment would be happiness -8. So there's not that equity there, and it's these sort of discrepancies that make us more inclined to write about negative experiences. And so because of those things, ratings potentially are always going to be against the physician. So it's important that now that there's social media, that you find ways to encourage your patients to put out positive feedback or encourage them to make positive comments on your behalf, because it's not second nature and it's not the easiest thing for them to do because it's just sort of outside of their normal comfort range. When we talk about complication rates, kind of going back to that question, again, it's all a matter of perspective as well, because you can have surgeons, for example, that do only high-risk surgeries, and so they're going to have high complication rates because the risk of the surgery inherently is much worse. When people look at those numbers comparing, say, a transplant surgeon from an elective surgeon that does hernia repairs, they would obviously probably gravitate more towards the hernia repair doctor because on paper their complication rates look much better. And this is where beforehand, when this information wasn't as transparent, you relied heavily on a physician, your primary care doctor, to help navigate which kind of specialist to go to. And I think now, even with social media, this is where your role as a physician still remains very, very important, that when you're reaching out to your patients, referring them to right specialists, that you explain what these numbers mean, that you have that discussion with them about what this information actually means so that it's easier for them to figure out. So that kind of covers it today. I mean, there's a lot of different areas that we can be talking about. We talked a little bit about HealthTap and some of the related sites to HealthTap we didn't cover, like Sermo and Doximity. We talked about kind of the social networking sites like Facebook, Google Plus, and LinkedIn. We didn't talk about too much. We talked about microstyle and blogging from Twitter to pure blogs and Tumblr and WordPress. Same sort of thing, Instagram, Flickr, YouTube, all these different areas where you can kind of share content and be involved. And so, as Dr. Vardabadian recommended, find an outlet where you think you will have the most meaningful exchange, where it's easier for you to update content and to have this be your voice. So for me personally, I like Tumblr and Twitter as my main mechanisms for sharing information. Some people really like using YouTube or Instagram to do more pictorial type items, or HealthTap. It really depends on how you like to manage your style. So with that, again, I thank you for your time and attention. I really am hoping that you guys feel free to engage in this discussion online. Reach out to me via email, Twitter, on the website, and we can talk a little bit more going from there. Thanks a lot, and we'll see you next time.